Good morning, everyone. This is the second part of the lecture about biliary tract, and in the previous lecture, what we did, um, I discussed the function, anatomy of gallbladder, as well as we discuss about the gallbladder stones, which can result into acute cholecystitis. And other than that, in the previous lecture, what we had discussed is I I talk about the Gallup triangle. I talk about the normal gallbladder. I talk about the variations of the branching, as well as I talk about the different investigations, which could be ultrasonography. We can do CT scan. Then I talk about the different type of investigations, which are very uh, specific to gallbladder. Is like one is magnetic resonance cholangiopancreatography, MRCP, as well as ERCP, which is endoscopic retrograde cholangiopancreatography. As you can see over here, they put a endoscope in the second part of the duodenum. From there, they approach through the sphincter of Oddi or OD inside. They introduce the endoscope, and then, of course, like they can see, uh, they can put a dye and they can visualize all the pancreatic duct and other ducts, biliary common bile duct and all the ducts. So, and also I talk about the PTC, percutaneous. See, they are approaching the duct percutaneously. You can see over here. Okay. So this is like kind of revision, and then there is something called as T-tube cholangiography. So now, today we are going to discuss the remaining topics related to the gallbladder, as well as the uh, the bile ducts, or what you can say, um, the extra hepatic ducts. Of course, intrahepatic are like within the liver, and extrahepatic like what are outside the liver. So whenever there is stone outside the liver or in the common bile duct, we call them as choledocholithiasis. So choledocholithiasis is simply the common bile duct stones. Okay, so when the stones are in the common bile duct, uh, we call that as choledocholithiasis. So as you can see over here, like they like here there are some pictures with stones. Okay, so the stones can be single, can be multiple, can be small, can be large, and the thing is, how we classify these stones is basically according to their point of origin. Um, for example, um, the stones can be primary, which mean um, that they are formed in bile duct, whereas it could be secondary, which means like the stones pass from the gallbladder into the common bile duct. Okay, so that's why I'm saying like they can be classified according to their point of origin, like where they originate basically. So, for example, the majority of the ductal stones or the common bile duct stones in Western countries, or you can say in developed world, is formed within the gallbladder, and then they migrate to the common bile duct. Okay, so or you, in other words, you can say like most of the stones in developed countries or in Western countries are basically secondary stones, whereas the primary stones are formed in the bile duct. Okay, so the secondary stones which are formed in the gallbladder are usually cholesterol stones, whereas the primary stones are usually pigmented stones, or you can say the brown pigment stones. So the primary stones are basically related to biliary stasis or infections, and they are more common in Asian countries or Asian populations. Okay, so and why there is biliary stasis? Uh, Simply, it could be due to stricture formation, due to tumors, or it could be due to secondary stones, by the way. Because, see, whenever a secondary stone will come and block the common bile duct, what will happen? That it is going to cause obstruction, and due to obstruction, there will be cholestasis, like the bile flow will be stopped, will be stagnant, and what will happen that it can lead to the formation of stones, which in this case will be primary stones, secondary to secondary stones, right? So that's how they are formed. So you can say like, see, the primary, um, they are mostly pigmented or mixed stones, and secondary from gallbladder are mostly cholesterol stones. And most in distal common bile duct, they are called as choledocholithiasis, as I told you. And simply what happens is like they cause obstruction. And once there is obstruction, it will lead to infection. So that is called as acute obstructive suppurative cholangitis now, because there is inflammation, which in severe conditions can lead to septic shock and death. Okay, so now talking more about the clinical features of these stones. Okay, most commonly, like, or mostly they are clinical silent. Okay, and they are found uh, during some procedure like cholangiography, or you can say, in medical we call it as incidental finding. Okay, so mostly these stones are asymptomatic, and or you can say clinically silent stones, which are not giving any sign and symptoms, and they are found incidentally when they are doing some other investigations. Okay, so but whenever, of course, they will cause obstruction, which could be complete obstruction, which could be incomplete obstruction. Of course, like as a result of that, it can lead to any condition like cholangitis, like pancreatitis, right? So you can see over here the pain which is caused by a stone in the bile duct is very much similar or same like biliary colic. Um, so a stone which is stuck in a cystic duct, or a stone which is stuck in the bile duct or common bile duct, the pain is somehow same. So you can see like there could be abdominal pain, there could be biliary colic in the right subcostal region, epigastric or substernal area, and as I talked in the previous lecture, there is a referred pain to the right scapular region with nausea and vomiting. Nausea and vomiting are very common. Okay, and there could be uh, chills with fever, of course, if there is a choline infection, and it can lead to jaundice, of course, because the stone is impacted. So, of course, the bilirubin will be elevated in the blood, which can lead to jaundice, right? So, in simple words, and remember, like when we are talking about the symptoms, we have to talk about all the symptoms, but it's not like this, like every patient will present with jaundice, right? So, or it cannot be like this, like that the physical examination will be abnormal in each and every case. Rather, it is like this, that physical examination can be normal or may be normal, but most often there is mild epigastric or right upper quadrant tenderness, as well as you can found jaundice, okay? And, and if you know the anatomy and the functionality of the gallbladder, the liver, the common bile duct, and how they are connected with the pancreas, the things will be quite clear. Uh, like for you, of course, like why the jaundice is happening, simply because it's a post-hepatic type of jaundice. There is obstruction to the bile flow. So, uh, any of these manifestations can occur in the patients. Okay. So, of course, like when the patient is having these things, then uh, we go for further investigations in these patients, right? So, talking about the investigations, for example, of course, like we will do the bloods, we will do the whenever we go for to investigate any patient, we go for to the uh, you can say the most commonly performed test, the basic test, less interventional test, and then we go towards the more interventional test. For example, in this case, you are going to ask the patient to do CBC. For example, you will ask the patient to check. You will check their bilirubin levels, or you can say you are going to check their LFTs or liver function test. You will check the bilirubin levels. You will check the alkaline phosphatase. You will check the ALT and AST or transaminases. Uh, you are going to check the gamma glutamyl transferase or GGT. So now, depending on like if the obstruction is complete, of course, LFTs could be abnormal, but LFTs could be normal as well. For example, if the obstruction is not complete, the LFTs can come back completely normal. So that's also the case. So other than that, like if we will talk about the specific test to diagnose choledocholithiasis or stones in the bile duct or the common bile duct, one very easy test, very commonly available, very cheap, very comfortable, and not interventional is of course ultrasonography. And ultrasonography is usually the first test, to like which the doctors perform. So it is very useful for to see the stones in the gallbladder, especially, as well as it is going to you will see either the bile ducts, they are of normal size or they are dilated, for example. Okay, so of course, like if you will found stones with dilation of the CBD or common bile duct, of course the things will become clear. Okay, so uh, and of course, like it depends on where is the stones impacted um, in the common bile duct. So one of the thing, by the way, to mention here is a dilated common bile duct of greater than 8 millimeter on ultrasonography in a patient who have gallstones, who have jaundice, and who is giving you the history of pain, okay, like the specific pain, which I already discussed, uh, is a very, you can say, a pointer, or you can say it's highly suggestive of common bile duct stones. Okay. And of course, like other than that, you can go for any other investigations. You can go for ERCP, which is both diagnostic as well as therapeutic. We can go for percutaneous one, and we can also go for CT scan, or we can also go for MRCP, right? Uh, so, uh, MRCP, or magnetic resonance cholangiography, or cholangiopancreatography, is highly sensitive as well as specific uh, in catching choledocholithiasis, whereas ERCP is the gold standard test for diagnosing common bile duct stones. Okay, because this one, ERCP, is highly sensitive and specific for choledocholithiasis. It is both diagnostic and therapeutic. Therapeutic means what? While doing the test, if you can see the stones, at the same time you can remove the stones. Okay, so what they do is, by the way, like during this procedure, they can perform a sphincterectomy. Like they can cut down the sphincter, or sometimes they like what they do, like they go beyond the stone. They inflate a balloon and they bring the stone outside. So the point here to mention is, guys, for example, in PLAB, they love to ask these kind of questions, like what is the gold standard test to diagnose choledocholithiasis. So remember, ERCP is the gold standard uh, in diagnosing as well as treating. Okay, so it is both diagnostic as well as therapeutic. So uh, PTC, whereas like the percutaneous, uh, uh, this procedure is really needed in patients with secondary common bile duct stones. But also, like we can do this test, like, but ERCP is the give the best results. Okay, you can see over here showing you the MRCP as well as the other testings. So both tests can be done, MRCP as well as ERCP. Okay, uh, and if you go for MRCP, of course, you have to do something. Uh, for example, a laparoscopic surgery to remove the stones. But ERCP is very good because it can be treated at the same time. Okay, and okay, differential diagnosis, of course, like I'm not going to talk about that as well right now, but the pain to the okay. Next lecture is about acute abdomen. You will have a better understanding about what we can think of when someone is complaining of pain in different parts of the abdomen. So, talking about the treatment, as I told you when I was talking about the laboratory investigations, so uh, the treatment is almost same like that one. So anyone who have gallstones and who presented with the signs and symptoms, of course, ERCP is one of the choice. Okay, so now not just this thing, but there are many other options. So one of the thing, for example, is uh, I would like to mention here ERCP, right? So endoscopic retrograde cholangiopancreatography. You can perform sphincterectomy. You can extract the stones, okay, from that patient. Okay. Okay, so one of the thing is like when we manage the patient by ERCP and sphincterotomy, half of the patients have recurrent symptoms of biliary tract disease if we will not perform a cholecystectomy. Cholecystectomy is, of course, taking out the gallbladder, of course, like, right? In the previous lecture, we have talked about that. Okay, other things which are available in these patients can be uh, there could be a T-tube drainage, uh, which we can keep for 2 weeks, and then cholangiography before pulling T-tube out. Uh, Sometimes we can do a choledoscope, cholangiojejunostomy. Okay, so there are many procedures, but let me rephrase them. So ERCP, then of course we can go for laparoscopic common bile duct exploration. Okay, so it is like, of course, by using laparoscope, and of course, like in this one, they can explore the bile duct and they can assess the common bile duct, and by that, like, they can remove the stones. Okay, uh, what you can say, from the patient, uh, right? They can remove that thing, and this thing is one of them. Okay. Other than that, what are the other things which we can do? Of course, like, other than that, the conventional methods or the older methods, open, uh, like, what we must say, that thing is um, like laparoscopic one, and then there are like the older methods. You can say like open common bile duct exploration can be done, right? Of course, like in this one, they are going to they are going to perform open surgery, they are going to explore all the common bile duct. Okay, with that, and then of course they leave a drain. Okay, uh, like we call it as T-tube. Okay, so a T-tube can be left in the place, um, and then of course, like they remove the T-tube later on. So sometimes, a surgery can be done which is called as choledochoduodenostomy. Okay, so of course, like in this one, what they do is like uh, they drain the thing, or they open up the thing inside the duodenum, of course, like, so that uh, like all the stones should pass in the duodenum. Okay, so this is like how they treat. Okay, you can see over here. So this is like how they treat the choledocholithiasis. And one of the thing, by the way, which can occur, or which can be a result of common bile duct stones, is like pancreatitis. Of course, when the pancreatic duct is blocked, so the things are going to build up in the pancreas, which can result into pancreatitis or inflammation of the pancreas, and in that case, we call it as gallstone pancreatitis. Okay, it is called as gallstones pancreatitis. So, of course, like pancreas and pancreatic duct, it combined with the other duct and make a common bile duct. And of course, what happens is like they both, most of the time, they both together drain into the duodenum. So of course, like whenever a stone is blocking the sphincter of OD, so of course, what will happen, like the pancreatic secretions are not going to drain into the duodenum, and pancreatitis can occur. Okay, so uh, this is what can occur in this case. So other than that, intrahepatic bile duct stones, guys, I'm not going to talk about much about that. But of course, like whenever there is stone inside, so depending on like either it's in the right or the left hepatic duct, of course, the liver LFTs will be deranged, and there could be infection, there could be fever, chills, rigors, jaundice, like uh, more or less pretty much the same story. And of course, we go for surgery in that case as well. Um, okay, so now, other than that, you can say, other than this, what are the topics which we are going to cover is one thing is called as cholangitis. See, one thing is called as cholecystitis, right, which we have discussed. So one thing is acute cholecystitis, and the other thing is chronic cholecystitis. Okay, and this is like, if you know, the patient present with the same abdominal pain, abdominal distension, fever, and when you will examine, of course, you will find enlarged and tender gallbladder. So we've discussed this thing before, and of course, to treat that, we what we do is like we put the patient on IV fluids, and we put the patient on. We don't give anything by mouth, and we start them on antibiotics. And the treatment is, of course, cholecystectomy, okay, which could be laparoscopic, which could be open one. And sometimes there could be chronic cholecystitis as well. Okay, one thing is called as cholangitis. Okay, so what is cholangitis? What happens is whenever there is stones or whenever there is choledocholithiasis, so uh, you can say cholangitis is one of the complication of the choledocholithiasis as well, or like same like I was talking about the gallbladder, or sorry, gallstone pancreatitis. So what happens is, of course, whenever the stones block the duct, what happen is there is bacterial infection which started ascending upwards, okay, uh, and uh, simply it can lead to fever and all the other signs and symptoms. We call this thing as cholangitis. Okay, so, or there's one thing called as acute obstructive suppurative cholangitis. Of course, when the obstruction of the bile duct is complete, so it can result into this thing. So the etiology, as you can see, biliary obstruction, a bacterial infection, and the principal causes, number one is choledocholithiasis. There could be biliary stricture, there could be cancers. So the thing is, the hepatic bile, the bile which is flowing inside the ducts, it is sterile. It doesn't contain any bacteria. And how it kept it is sterile because it is in continuous flow, and the bile have a lot of immunoglobulin, so uh, usually there is no infection. But once there is obstruction, of course, what happens is it can result into bacterial contamination as well as infection. So now the most common cause of cholangitis is gallstones, of course. The gallstones are the one which block, okay, and of course, like you can see, there are many other causes. For example, neoplasms, right? For example, strictures, this one. So there are many other causes. Okay, the most common organisms, which they found in cholangitis is E. coli. There could be Klebsiella, Pseudomonas, Streptococcus, Enterobacters, Bacteroids. Okay, so they found like number of bacteria in this case. And again, the same thing which I was talking about, like what is the pathophysiology or how it occurs, simply due to obstruction, and most commonly due to stones. So now how it present? Uh, this is quite interesting, and again a very common questions which can be asked in different examinations. I always give the example of PLAB because uh, other exams, they give like quite long scenarios, okay, like a full clinical scenario they give, and then you have to see the clinical scenario and answer it accordingly. But in PLAB, like they love to ask like short questions, one liners and things like this. So for example, now cholangitis is infection, like as we know. So cholangitis, now not every patient present with the same intensity. Some of them they have mild disease, some of them they have self-limited disease, but some of them they have life-threatening disease as well. So uh, most of the patients who have cholangitis, they are old and they're females. And the most common presentation is fever. Okay, the most common presentation is fever with pain, and of course the pain is epigastric or right upper quadrant, and jaundice. Okay, so pain, jaundice, fever, fever with chills. These three features collectively called as Charcot's triad. Okay, these three clinical features are collectively called as Charcot's triad, and uh, so biliary colic or pain, then there is jaundice, and then there is fever, right? Basically, biliary colic is pain which starts from P, and fever is pyrexia which again starts from P, and then there is J, jaundice. So how I remember this thing is PPJ, right? Because it's a very, very common asked question. And why this Charcot triad is important? Because 2/3 of the patients who have cholangitis, they present with Charcot triad, or they present with these features. But this condition or this cholangitis can rapidly progress to septicemia, and the patient, due to that septicemia, can be mentally disoriented. Okay, so this one is important, but just to add in your knowledge, the patients who have a serious type of disease, it can lead to two more things. One is septicemia and altered altered mental status. Okay, or you can say altered level of consciousness, or you can simply say disorientation, right? This three things, okay, one, two, three, four, and five. These five things are also called as Reynolds pentade. This is a triad, this is pentade. Fever, jaundice, pain, septic shock, and mental status changes collectively called as Reynolds pentade. Okay, so uh, these are the clinical features of simply cholangitis. Okay, very easy to remember. So of course, then we will go for the investigations, and in investigations we will what we will do is like we will do the bloods, we will do the CBC. You will found leukocytosis, the white blood cells will be increased. You can get the LFTs. You may found hyperbilirubinemia, elevated alkaline phosphatase, transaminases can be elevated. Okay, and of course, if there could be septicemia, you can take a blood culture, and again, a very easy test which we can do, ultrasonography. Ultrasonography is very helpful. It can show you gallbladder stones, it can show you dilated ducts, it can show you the site of obstruction. Okay, so this thing can be done. And okay, I already talked about that. uh, Signs, of course, the same. And other than that, uh, we can go for ERCP. Okay, so ERCP is a very nice diagnostic as well as therapeutic procedure. You can see the obstruction, you can take a sample from the bile to culture it to know what bacteria are present, as well as you can remove the obstruction right away, which will drain out all the bile. Okay, and you can place a stent at that place so that the things will keep on draining. Okay, and of course the patient can be treated, right? So this is about the investigations. But when we will treat the patient, how we treat the patient, of course it's an infection, we put the patient on IV antibiotics, we give them IV fluids, we don't give anything by mouth, we put them on NPO, nothing per oral, we decompress the GIT, we put an NG tube. And of course, if the patient is not well, or he's septicemic, or he have altered level of consciousness, then of course the story is different. You are going to admit the patient right away into the ICU, okay, to stabilize them. And once the patient is stabilized, of course, what will happen? Things should be done to decompress the biliary tract, and how to do that? Again, the same thing: ERCP or PTC, whatever is available, right? So this is how it is treated and how this one is managed, right? Okay, so, and of course, like emergency endoscopic sphincterotomy and laparotomy, bile duct decompression, which can be done by PTC, which can be done by ERCP. Okay, there is one more thing which is called as acute acalculous cholecystitis. Like sometimes, the obstruction of the cystic duct can occur in absence of the stones. We call it as acute acalculous cholecystitis, which means like there is cholecystitis, it is acute, but it is acalculous. Like there is no stone which is blocking the tract. Okay. Now, other than that, what we can discuss is uh, um, okay. Okay, what we can discuss more is the gallbladder masses. Okay. Okay, so talking about this one, what kind of masses can be there and what kind of carcinomas can be there? Like, of course, masses can be benign or masses can be malignant. Benign one and malignant one, of course, like uh, we will talk a little about the gallbladder carcinoma. We will talk a little about cholangiocarcinoma, right? But and we will talk a little about other masses like polyps of the gallbladder, right? So if you can see the polyps of the uh, gallbladder, so non-tumorous polyps, okay, these are the most common. So simply, in other words, you can say like the most common masses in the gallbladder are not cancerous, like they are benign, and they could be adenoma, or they could be polyps or pseudotumors, you can say, and which can be as a result of cholesterol stones or cholesterol polyps, okay, or which can be due to adenomyoepithelium hyperproliferation, or it could be due to some inflammatory processes. So, and the tumorous polyps could be benign, which is adenoma, or it could be malignant, which is adenocarcinoma. Okay. Now, the important thing to understand over here is simply what can be the clinical features of, for example, benign masses of gallbladder. Okay, so of course, like the things will remain same. Okay, one more thing is sorry, I forget to mention here is there could be cyst formations as well, right? You know what a cyst? Okay, it is like the collection of the fluid which is lined by epithelium and biliary cyst, or you can say choledochal cyst. You know, they are also you can say not so uncommon simply. And whenever there is any tumor, any mass which is benign, for example, the presentation can be okay, the mass can block the bile flow simply, and the patient can result or can present as jaundice or pain. Like the presentation, like what I want to convey to you, or what I want to mention over here is like simply the presentation can be same like cholecystitis, okay, or jaundice or cholangitis, whatever, right? So simply you can have to remember these things, okay. Of course, like if there is a carcinoma, the features will add up, like there will be weight loss, there will be a loss of appetite and all this stuff. But whenever there is any mass in the gallbladder or in the bile ducts, when the mass means like polyp, a cyst, adenoma, the patient will present with right upper quadrant pain, can present with jaundice. On examination, you can palpate a mass, okay? If it's not a carcinoma. If it's a carcinoma, of course, the things will add up. So, whatever it is, it's a polyp, it's a cyst, it's any benign mass, uh, and the patient is presenting with some features of upper quadrant pain, of jaundice, of like anything like this. Of course, you will go for the investigations, okay? So investigations, of course, like what kind of investigations we can do in these patients. Uh, I think like by now you must know what are the different investigations which are available. Okay, which we can do in the patients. Uh, of course, like to know where is the mass, or to know how big is the mass, we have a number of you can say investigations available. We can go from ultrasonography to CT scan to ERCP to MRCP. Okay, all these tests are available simply to check like where is the tumor. And um, the good thing about the interventional test in this case is, of course, we can take a sample, and the sample can be sent to the labs, and the sample can be checked, and like a histopathology of the sample can be done, and we can see like what it is made up of, either it's a benign or either it's a malignant tumor, right? So this is how we do. And you can see over here, like size more than 1 centimeter may be malignant, and shape papillary may be benign, while irregular can be malignant. And multiple polyps are cholesterol, single one adenoma or adenocarcinoma. And site malignant polyps in the corpus are easy to invade the liver. And symptoms, like of course surgery is considered on that case. For example, see, this is ultrasonography, you can see over here, and they found a mass in the gallbladder. So other than that, let's discuss about gallbladder carcinoma, and then we will talk about the um, cholangiocarcinoma. Okay, so carcinoma of the bladder, gallbladder, not bladder, gallbladder. Okay, first of all, the carcinoma of the gallbladder is a very rare malignancy. So Why I'm stressing this thing out? Because if it is very rare, guys, it's not so important. Okay, it is very rare. It is uncommon. It occurs or it affects the elder population. Okay, but it is a aggressive type of carcinoma. So remember, all the aggressive type of carcinomas, they have bad prognosis. Simply, the prognosis is not good. So uh, now, um, very rare, affect the old people, but very aggressive. So when it is aggressive, of course, the results are not good. Or you can say, like, if it is not diagnosed at early stages, the patients die. Okay. So now, uh, you can see over here, like most tumors are adenocarcinomas, and very less are other types, right? So some are squamous carcinomas as well. Okay. The important thing, the cause or the etiology. Choledocholithiasis is the most important risk factor for gallbladder carcinoma. So what they found is like 95% of the patients who have carcinoma of the bladder have had or have gallstones. Okay, so simply, uh, the patients who have gallstones, they may have gallbladder carcinoma in old age. Okay, this is one of the studies they found. So that's why, whenever they found any lesions in the gallbladder, so they found any stones in the gallbladder, they know like the risk of malignancies are high, so they remove the gallbladder. Okay, in those cases. So the most common is adenocarcinoma, and then there are other types as well. Okay, so now, what are the clinical manifestations or clinical findings? You can see over here again the same things, guys. There is no difference. But as it is carcinoma, the things which will add up is the features which are related to carcinomas, like weight loss and things like this. So uh, you had done cholelithiasis, you had done cholecystitis. The features will stay same. The patient will present with pain, nausea, vomiting, weight, jaundice. Now, because it's a carcinoma, they do have weight loss, they do have anorexia, and uh, now, depending on how much spread of the carcinoma is there, the features will be of that. Okay, so what are the clinical findings which we will do is you can go for a ultrasound examination, you can go for a CT scan, you can go for MRCP in this case. Okay, but of course, like as it's a carcinoma, so what they will be doing, like they will do the staging. Okay, so the same TNM staging is done. So how they do stage, like they check the lymph nodes, they check the metastasis. Okay, either it is present or not, they will see the size of the tumor, and then they are going to grade the tumor according to that. Same TNM stagings are there. I did not include those TNM stagings here, but of course, like any surgery book, you can find the TNM staging. Like, by the way, there is no need to remember the TNM staging, so that's why I did not include this thing over here, right? So simply, like TNM staging can be done of the patient, and the treatment is of course like cholecystectomy. Okay, surgery is the main option which is available over here. So surgery should be done, but if, for example, uh, surgery cannot be done, like for example if the cancer is too much spread, or like the cancer is unresectable, because sometimes the cancer is so much spread, like it is already blocking the duodenum, it is already uh, invading the other structure. So of course, in that case, we will do palliative therapy, right? So when the tumors which are related to the which are limited to the gallbladder, which are basically T1, cholecystectomy is the best thing, okay, and it have a good survival rate. But for example, like when the tumor is invading the liver, or you can say extended beyond the gallbladder, of course, like then you have to resect the gallbladder, you have to resect the tumor, or like which have involved the liver, uh, and you have to remove the cystic duct. You have to remove the lymph nodes around that. Okay, and the prognosis is not so good. And same thing with T3 and T4, of course, like because the different things are now, you can say, involved, so it is hard to remove, it is difficult to manage. Okay, so of course, like that completely depends. So see, cholecystectomy with en bloc wedge resection of an adjacent liver, normal liver, and dissection of the lymph nodes, lesion invading bile duct, and produced jaundice should be resected if possible, and stent inserted endoscopically or percutaneously. Okay, so simply, the prognosis is not good, guys, of this one. And most of the patients, who have gallbladder cancer, when it is diagnosed, it is already advanced stage, and that's why the 5-year survival rate of this cancer is less than 5%, you can say, right? So, uh, if of course, like the tumor is diagnosed at T1 stage, the prognosis is very good. But if when the tumor is not diagnosed like at early stages, the diagnosis is not good, and 5-year survival rate is not good. Uh, the last thing is malignant tumors of the bile duct. Okay, simply biliary tree, you can say, the malignant tumor of the biliary tree. And you know what it is called as? It is called as cholangiocarcinoma. Cholangiocarcinoma. Okay, so it is called as cholangiocarcinoma. So now cholangiocarcinoma is again, uh, it's a rare type of cancer, of course. Okay, or bile duct cancer, is a rare type of cancer. So it's a rare cancer, and it arises from the biliary epithelium, and again, it is more common in females. Okay, uh, and the same story of gallbladder, it shared the same story, like uh, most of the patients when they are diagnosed, the disease is already advanced. Okay, so that's the reason, like, again, this one have a very bad prognosis, because most of the patients we cannot find it early. Okay, so uh, the risk factors, one of the risk factors which I know is like, or which I remember, by the way, is like primary sclerosing cholangitis, which is very common in females. PSC, PSC, primary sclerosing cholangitis. Patients who have ulcerative colitis or congenital dilation of the bile duct and gallstones, they have more cholangiocarcinoma. So this thing, and there are many other risk factors they found, like, it is associated with liver fluids, dietary nitrosamines, and exposure to some agents, things like this. But uh, and remember, like, this primary sclerosing cholangitis is a autoimmune type of condition, right? Uh, which can cause what you can say, this cancer, cholangiocarcinoma. So the clinical findings, you can say over here, is most of the time, uh, there is painless jaundice. Okay, painless jaundice is the most common presentation. Okay, I must add it over here. So painless jaundice is the most common presentation, okay? And other things, it could be pain, it could be pruritus, it could be anorexia, it could be fatigue, okay? It could be weight loss, okay? So uh, these things can be there. So then, of course, we go for the physical examination, and most of the time the physical examination is all normal except for jaundice, okay? Like the only thing uh, which we can found in these patients is basically jaundice, okay? And now, of course, like the thing is, um, there is one law that is called as Courvoisier's law. Wait, I would write over here. I just remember like this thing from MCQs, again a favorite type of question which can be asked, that is called as Courvoisier's Voisier's law. Okay, so what is this law, by the way? It is also called as Courvoisier's sign. Okay, so they say in the presence of a palpable enlarged gall bladder, which is non-tender. Okay, so in the presence of a palpable enlarged gallbladder which is non-tender, okay, no, non-tender means like on examination when you palpate that, okay, there is no tenderness in that area, you cannot appreciate the patient is not feeling any pain, and accompanied accompanied with mild painless jaundice, okay, the cause is unlikely to be gallstones. Now see this law. If you will pay a little attention on this one, you would understand. If the if there is palpable gallbladder, but it is non-tender, and there is mild painless jaundice, the cause is unlikely to be gallstones. So what it means, like in gallstones, there is pain, there is tenderness, right? So this is called as Courvoisier's law, and it is very, 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 you can say, important thing to remember. Why? Because see, it can, uh, what you can say, it can lead to the diagnosis of that carcinoma. Okay, so this is like how the carcinoma present. Like the patients, basically, they don't feel any. They have painless jaundice, right? And they may have pruritus, but they have like a mild upper quadrant pain. So this is like how this is what is Courvoisier's law, and this is like how it is connected with this carcinoma. So of course, like we will go for the investigations. We can do again the same story, ultrasonography. We can do the LFTs, and you can go for the tumor markers in this case. Okay, so tumor markers can also be done in this case. Okay, tumor markers can also be done in this case, and CT scan, MRIs, all these things can be done. And of course, like the ultimate thing is, of course, like we will go for staging. We will take a biopsy, and once they know like that the patient have um, a carcinoma is proved, then we will go for the staging. Okay, so the staging, again, the TNM staging is used. Okay, and as you know about TNM staging, like T is for tumor, N is for nodes, and M is for metastasis. Okay, so simply like when the tumor is confined to the bile duct, it is T1, but when it invade beyond the bile duct wall, it is T2. Okay, and same like as it will increase. So of course, like the treatment for the patients who have this cholangiocarcinoma is of course, okay, surgical excision, and what they do, like they explore the area, they remove any metastasis, or like wherever the tumor is, of course, like they remove that area. Okay, so they are going to surgically resect that. Uh, and after that, of course, like they have to reconstruct that area. And for reconstruction, okay, see, so whenever the cancer is like in distal one, whenever the cancer is in the middle one, so choledocholithiasis can be done, or pancreatidodenectomy can be done. So simply whenever like there is a patient, they are going to resect that area, then they have to reconstruct that area. Okay, so they resect the ducts, they remove the gallbladder. Okay, sometimes they remove like all the nodes and whatever the area is involved, and then they have to reconstruct that area. So reconstruction is performed using a limb of the jejunum, as you can see over here. Okay, so there are different ways of reconstruction, by the way. This is one of the way which is shown over here. Okay, so uh, sometimes this surgeries can be done for palliations as well. Okay, so that's all. Okay, so yes, and one very important thing, yes, I forget to tell you, one thing is called as Whipple's procedure in this case. Okay, Whipple's procedure. Whipple's procedure. Okay, wait. Whipple procedure. A Whipple procedure can be done. Okay, so uh, I think like it will be